A very good afternoon to all of you present here. I extend a warm welcome to all of you for yet another webinar in the Cutting Edge series. Uh, Team POGS extends a hearty welcome to all of you. We have Dr. Meenu Agarwal, our president, Dr. Vaishali Savan ma'am, our general secretary, and Dr. Charulata Bapai, our clinical secretary, here for the webinar. So now I request Dr. Vaishali ma'am to take over the session from here.
Yeah. Thank you, Dr. Sandhya, for the warm welcome. And it's indeed an honor, a great privilege to welcome such big names and dignitaries of Foxy for this cutting edge webinar series. This is the third webinar of our series, and this is by Pune Obstetric Gynec Society. And today is indeed very, very special because we have with us Dr. Hema Divakar as chief guest, Dr. Ramani Devi as guest of honor, and Dr. Ashwath Kumar as guest of honor, and very eminent speaker, Dr. Nozer. Sir has been our teacher, is the teacher of teachers, and we are truly blessed to be hearing Sir today. And a talk by Dr. Meenu Agarwal, President. And we are doing this in association with Kottayam OBGYN Society and Adur OBGYN Society. So thank you, Dr. Prasanna Kumari, for being here, Dr. Beena Kumar for being here, Dr. Sairyak, and Brigadier Sanjay Singh. So we would like to proceed towards the inauguration and receive the blessings and wise words of wisdom from our chief guest, guest of honor, and the dignitaries. Can we have the inauguration?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
So I request Dr. Hema Divakar, very, very dynamic leader, Foxy and Figo. And it's indeed a great honor for us, ma'am, to have you here with us today. Ma'am, we would like you to say a few words and give your blessings.
Namaskar. It's indeed equally my pleasure and privilege to be, as I told prior to the start of this webinar, to spend a few moments with the people who are very, very close to my heart and the favorites. Meenu, the president, Vaishali, the secretary, Charu, the clinical secretary, who have brought us all together with the cutting edge technology of the Zoom platform, which has now become a household kind of a lifestyle routine for many of us. And the beauty of this is the connect between the Pune, Kottayam, Adur, a mix of the best of people with my guests of honor. It's an honor indeed to have Ramani Devi, who is now currently the president of the TNFOG, or the Tamil Nadu state, which is racing fast ahead in delivering the best of the care to their girls and women in their state and beyond. And of course, the other beloved person, Ashwath, who's always quizzing everybody in the whole of the country and gets us to our knowledge that we don't know so much. And of course, there is a good spread today, right from monitoring the follicles for you, right until the joys of motherhood between Meenu and Nozer. They're taking us through an entire spectrum of two different worlds. The anxieties that one may have during the phase of assisted reproductive technologies, biting their nails, waiting for their results. And of course, when we say joys of motherhood, It is the joy when she first hears that she is pregnant, and also the joy after she delivers. But intrapartum period, oh my God, it can be a nightmare for many. How do you turn it around to be a positive experience, to have the mother remember even that phase of the period, which is very precious and painful on many occasions? People like Nozer could turn anything around, as you know, and you will hear from him about taking her through the intrapartum phase to lead her to the joy of motherhood. So I immensely appreciate that you have put this brilliant program in the Cutting Edge series, and may I wish every delegate who has hooked on to these deliberations will carry back rich experience of imbibing the best practices and the wisdom of the great speakers who are here to translate them into the practice. May you have a great, cherished memory of this webinar, and thank you for making me a part of it. Namaskar.
Thank you, ma'am, for these wonderful words of wisdom. Thank you very much. I now request Dr. Charulata Bape to give introduction of our guest of honor, Dr. Ramani Devi.
It is indeed my proud privilege and pleasure to introduce dear Dr. Ramani Devi, madam. Ramani ma'am can be called as the queen of endometriosis. And in spite of her large stature, in spite of her entire amazing academic contributions, she remains so grounded. We've discussed time and again about the illustrious family to which she belongs, her sisters, and everybody in her family who are doctors. So she has a great legacy behind her, with her, and she, continues to impart knowledge at each and every step. Whenever she meets youngsters like fledglings in Foxy like us, she's always been a guiding source to all of us. Madam, it was a pleasure to be at your place in Trichy last year. It was wonderful that you welcomed us with such open arms so late in the night, also after we finished our beautiful shopping expedition. And we have fond memories of the amazing time which we spent with you, whether it was there, whether it was in Jaipur, or in any other Foxy conference. Welcome, madam, to the Cutting Edge Technology webinar as our guest of honor, and kindly guide us, with your words of wisdom.
Thank you, Dr. Charu. I think it is a different type of introduction. Rather than telling what is a credentials for that particular guest of honor, you have, I'm really amazed to see how you are remembering everything, each and everything, the association with me. And I also really love to be a part of this very important webinar, Cutting Edge webinar, a series probably under the guidance of Pune OBGYN Society. Thanks to Dr. Meenu and Vaishali and all the president and secretaries of Adur Society and Kottayam Obstetric and Gynec Society. See, the two topics chosen today are very, very practical for any basic gynecologist who has got some sort of interest in infertility. I think the first topic should have come first. The second one should have come first. Follicular monitoring for IUI, that is followed by a pregnancy which needs to have an intrapartum care. And Dr. Meenu is such a good endoscopic as well as imaging science person. And I think the people can get a good knowledge regarding this follicular monitoring, because there are so many issues. Sometimes we start with a one drug, single drug, or sometimes we add up with gonadotropins, and to our surprise, we find multiple follicles. And then we should know to differentiate when you should continue with IUI or when you should shift to the ART. So there are certain very important points regarding whether this follicular monitoring is appropriate, whether it is going to give appropriate follicles so that we can have a good pregnancy. And coming next to the intrapartum care for joyful motherhood, I think you can find none other person than our respectful Dr. Noshasriya. Please, every woman wants to have a very, very joyful motherhood, and that too the intrapartum care is very, very needed, essential she must have a very good lingering memories of her intrapartum period, so that pregnancy will culminate in a healthy and a good maternal and perinatal outcome. I think these two topics are very, very essential, and I congratulate the Pune Society as well as the Adur and the Kottayam Society for having chosen these two topics, and thank you for the opportunity given to me. Thank you.
Thank you, madam, for giving us your blessings and best wishes. I would now like to, yes, Meenu?
Please go
I would
ahead.
now like to invite our guest of honor, Dr. Ashwath Kumar. As you know, he is very well-known laparoscopic surgeon, and at Pune we have witnessed his surgeries with big uterus, where he has done flawless surgery, and in a matter of less than an hour, myomectomies and TLHs and so on. So he is a very accomplished laparoscopic surgeon, past Vice President Foxy and now President KEFOG. So it's an honor to welcome you for this webinar.
Thank you, Vaishali, for all the good introduction. First of all, thank Meenu Madam for my invitation by Dr. Vaishali, Dr. Charulata, and Prasanna Madam, President Adur Society, Beena Kumari Madam, President Kottayam Society for the invite. And it is very nice initiative from Pune Society. Whenever Pune has called me, I have never told no. I have been attended almost, if you ask me, the maximum programs I attended in my Foxy, after joining Foxy, is in Pune Society. How many times in a year? Minimum 2 times in a year I would have visited Pune for. And next week again I am coming. They're not this week. This Friday again I am there. So very happy to be associated with Pune Society. Our speakers today are excellent, and Nosar sir is the guide. I'm so happy to see him today. Guide in Foxy to me. Otherwise, I would not have stepped into the any positions in Foxy because of his encouragement. I carried forward. Even if sir did not become the president of Foxy, I was pushed till the vice president of Foxy. Thank you all for the encouraging words and encouragement to being in the association. Anyway, about the topic, both of them have told you are all eagerly waiting for the topic, so I don't want to take your time. Once again, all the best for your webinar, and congrats for association with different societies and maintaining that friendship. This is the best way. Nowadays, Zoom is the best platform that you can utilize to be, and seeing all of you. Hema Madam, I have seen for a long time. I had not met in conferences, so nice that we met all of you here. I have just finished my tenure actually last week in Kerala, All Kerala Presidentship. Anyway, so I am the after past finishing the tenure. This is my first webinar. So 2 days before I finished. Anyway, thank you all for inviting me. See you in Pune. Okay, thank you, sir. Thank you, everybody.
Ashwath, 2 days back only I took over as the president.
You took over. And Remedy Madam, I was there for the installation of the Trichy Society 2 weeks back. And I was the installation ceremony. I was the chief guest of honor. Okay, thank you anyway. Thank you.
Charu, you mentioned about Ramani Madam's legacy. Her father was the first surgeon of Tamil Nadu. That is
Trichy. First
surgeon of Trichy. So when there was an oration in her mother's name, so when they were telling about the whole history, that is when they mentioned. So huge legacy, madam, that you have.
Thank you, Meenu.
Thank you, Dr. Ashwath, for those wise words, and we are looking forward to meet you over this weekend and listen to your talk at the plenary session. Yes. So thank you, our respected chief guests and guests of honor. With this, we come to the end of the inauguration and we move ahead with the scientific session. I request.
Thank you, Vaishali ma'am. Thank you, Vaishali ma'am, for the kind introduction of all the guests of honors and chief guests. It was really nice to hear from all of them. So now we move on to the scientific session. So first session is by none other than Nosar sir. And for his talk on intrapartum care for joyful motherhood, I would like to invite the two chairpersons. Our first esteemed chairperson is Professor Dr. B. Prasanna Kumari ma'am. She is the Honorable President of Adur Society. She is the HOD and Senior Consultant OBGYN and Lifeline Hospital Adur. She's also a Senior Consultant at SUT Hospital Trivandrum. She is the former professor at Government Medical College, Calicut and Trivandrum. Author of Postgraduate Gynecology. She was awarded the WHO Fellowship in 91, and she is the former President KFOG. And our second esteemed chairperson, is none other than our lovable, our General Secretary, Vaishali Chavan ma'am. She is director at the Cloud9 Hospital, Kalyani Nagar, Pune. She is, as I said, the General Secretary. And for this term, also she was a chairperson, Perinatology Committee, FOXI 2018-20. She has many publications to her credit, and she has received various awards like Punya Bhushan Award and Samaj Bhushan Award, to name a few. I would request Prasanna Kumari ma'am to introduce Noser sir. Thank you, ma'am.
Thanks to Pune Society for including us in the webinar. To the introduction, let me introduce Dr. Noser Sherrier, who is an exemplary speaker known all over India and associated with FOXI in several years. And I still remember most of his talks when he gave the talk in Kerala. Professor Noser Sherrier was the past Secretary General and the past MTP Chair of FOXI. He was the past President of MOX and consultant to several hospitals, Breach Candy, Hindu Jakar, and Holy Family Hospital, scientific chair of the 22nd FIGO Congress in Rio, and he delivered 16 orations and over 500 presentations. He edited 5 books and published 33 papers and 56 chapters, very academic. He has been honored FRCOG from the Royal College, and he got the Young Gynecologist Award of AFOG, and FOXI, Hansotia Best Committee, and Dr. Datta Best Publication Award. He will be taking us through the pain and anxiety and difficulties and guidelines of labor and the joy of motherhood. To you, sir. He is a celebrity's obstetrician.
Thank you. Thank you so much. Really a privilege to be speaking at a symposium organized by 3 societies of FOXI. And I think one of the finest things that we have in FOXI is partnerships, and this is true partnership. I wish more societies did join programs and brought each other. I'm going to start with sharing my screen. So Sandhya, are you able to see my screen?
Yes, we can see the slide mode.
Thank you. Thank you. So today I'm going to speak to you about the difficulties. As was mentioned earlier, for labor to be safe, we sometimes have to go through difficulties and challenges. And I remember reading about the Mount Everest, which is said to be the climber's toughest journey, the toughest journey in the world. And they say that the biggest enemy when doing this climb is the weather, which can change suddenly. And every year, a few very experienced mountain climbers actually lose their lives. Now, what happens is that when the weather changes, a mountain climber should turn around, irrespective of how close they are to the summit. And there was this time when 15 climbers died in a year, but out of these 8 died in a single day. And their mistake was that they continued past the turnaround time. Now, Chris Gaines has called this the destructive passion for one's goals. The climbers are so possessed by the goal that the closer they get to the summit, the harder it becomes for them to turn around. The more we are driven by the passion for our goals, the more likely we are to override important signs of risk. We become so obsessed that we avoid course corrections when the conditions under which the goals were set changed. I speak as an obstetrician in the second stage. And I believe that sometimes we obstetricians tend to have this destructive passion for one's goals. And we become so determined to continue on a certain path, even when we should give up, that that's where we land up with complications. That inflexibility has serious consequences. In fact, on a lighter note, one of my associates who's worked with me for many years, I've actually empowered her to whisper in my ear Mount Everest if she thinks Dr. Sheriar is taking too many risks. And sometimes we need to have someone there to be that voice outside our head. So today, let's talk about the second stage. I present to you a do and don't guide. And I believe that wherever possible, we must anticipate, we must avoid. Only when we acknowledge can we take actions. And Aswath was there today. It is loosely based on an oration that I gave at the KFOG conference when Aswath took over as the president. So let's start off with the beginning, what we are taught as young doctors in medical school. We are taught about the power, we are taught about the passenger, and we are taught about the passage. So let's look at the power first, uterine contractility. And when things are not working well, Henry Bergson has said, think like a man of action, but act like a man of thought. First, let's look at contemporary definitions. Second stage of labor, which was like upper limit 2 hours in a primary and 1 hour in a multi, has now been extended to 3 hours with analgesia and 2 hours with analgesia in a multi. But the newer guidelines say that all durations may be extended by an entire hour. And I can tell you from experience that sometimes when you wait long enough, nature does all our work safely for us, as long as the mother and the child are fine. Protracted descent is when in a nully, it's happening at less than 1 centimeter per hour, and in a multi, less than 2 centimeters per hour. And here you could have an arrest or failure of descent. Now we have to understand that you could have two situations here: hypotonic uterine contractions and hypotonic uterine contractions. In the hypotonic, the baseline tone is elevated, and this pressure gradient from the top of the uterus to the lower part of the uterus is distorted. It may happen because of uterotonic agents. It may happen because of mechanical dystocia. It might happen because of very strong perineal resistance. In contrast, the hypotonic uterine contractions have a normal gradient, but the pressure just doesn't seem to build up. It could be a tired uterus in a prolonged labor. It could be inadequate contractions. It could be dense analgesia. And please always remember the over-distended bladder, which we very often forget to pay attention to, particularly when there is an epidural. How can we avoid this? For hypertonic, be very judicious with use of oxytocics and titrate them. Don't go crazy. Don't try to rush a labor. Do not use multiple agents together, always one at a time with enough time for them to clear out from the body. Sequential use can be safe, but concomitant use can be dangerous. And finally, of course, rule out cephalopelvic disproportion. Hypotonic, avoid prolonged labors, routine partography. Inadequate uterine contractions need to be addressed. Ensure adequate analgesia. Don't go overboard with the epidural, and frequent emptying of the bladder. Now, what happens if there are hypertonic contractions? First of all, exclude mechanical obstruction, because the uterus is trying to push past. But for all of us, if there is a hypertonic activity, you could use terbutaline subcutaneously every 20 minutes. Unfortunately, not easily available to us, but we have nitroglycerine available to us, which could be either given IV, or this is one time when I might use nitroglycerine sublingually. And of course, if delivery is not feasible, just go for a C-section. Hypotonic, ensure effective emptying of the bladder. Titrate the augmentation judiciously. Await adequate uterine activity, and most importantly, resist the temptation of delivering a fetus in a fully dilated mother when the uterus is not contracting, because you could land yourself up with a torrential postpartum hemorrhage. So be patient, wait, leave her alone, but wait for the contractions to build up. And of course, monitor sustained activity and a time frame. We now come to the passage, and we'll talk about mechanical eutosia and mechanical dystocia. Baldwin has said not everything that is faced can be changed, but nothing can be changed till it's faced. Now, one of the things that has become an inherent part of my practice is the perineal massage. If you want to make the passage better, every patient of mine starts doing a perineal massage for herself with an Ayurvedic oil that we've kind of sourced in our clinic from 36 weeks to term. This was a Cochrane database, 4 trials, RCTs, which showed that there was less trauma requiring suturing, less episiotomies, and there was no difference in instrumentation and sexual satisfaction. Extremely well accepted. You see how the woman does it very easily. She can do it herself with 2 thumbs and using any kind of a lubricant or oil, or she can have a partner help her out. And that brings us to the use of selective versus routine episiotomies. Now, I know we Indian gynecologists are taught, as I was taught, and as I taught my students, that the Indian woman has a very rigid perineum, a very small perineum, and that's why she needs an episiotomy to protect the perineum. This is Cochrane, 2017, 12 RCTs, 6,177 women. Selective episiotomy reduced perineal and vaginal trauma by 30%, minimized blood loss, had no effect on the Apgar and no difference in perineal infection. This is, of course, for an unassisted vaginal birth. I routinely do not use an episiotomy for my vacuum deliveries, but for my forceps deliveries, I still do. So how do we manage it? Well, firstly, I must confess here that I do have a very liberal use of vacuum. I prefer this particular cup. In this case, we are using the Mitivac. I used to use the Bird's cup, and recently I've shifted over to the Kiwi cup. Now, you may wonder why I'm using this vacuum, and this woman could have delivered in a few pushes. Well, for 2 or 3 reasons. One, I can actively control flexion and extension of the head. You can see here, we are flexing the head and we actually bringing in the sub-occipito-brygmatic diameter of 9.5 centimeters into action. You will also see that while I could have pulled this head out in a second, take your time, do it very gently, give the vulva enough time to stretch. There is no episiotomy in this particular patient. And gradually, once you deliver the head by extension, all the stuff we are taught when we are in our second MBBS, in our first gynec term. And trust me, when you deliver a head this way, gently, slowly, and not let it pop out like the cork of a champagne bottle, you will have the least perineal trauma, right? And you can see we are delivering the baby by extension. In fact, I can tell you that for me, it was a revelation. Till maybe 2015, 16, I was someone who almost routinely did episiotomies in primaries. And then I realized we actually had a complication where we had a rectal injury. And then I went back to what my friend Geeta Arjun used to tell me. She said, you know, Noza, if you go to a fabric shop, the salesman makes a little cut and then tears the fabric. If he didn't make the cut, the fabric would not tear. The episiotomy is the cut on the fabric. This was 200 deliveries in 21-22 that we did, and we delivered almost 85% of them without using an episiotomy, and the majority of these were actually primicravidae. Before that, in 17 and 18, we were maybe 75%, and now we've gone to 85%. And most of the patients who had an episiotomy were actually patients where we had to do a forceps delivery. Now, of course, if I do this, I will have perineal tears. And I can tell you today, I do not fear perineal tears. This is the classification, both ACOG and Green Top guideline of RCOG carry it. First degree, second degree, third degree, also subclassified into 3 and 4th degree. I am not afraid of first and second degree. Thankfully, in our series, we didn't really have any 4th degrees. We did have a few 3rd degrees. And today, I believe, with the right amount of skill and suturing, we can deal with these very well. In fact, since this video, I can tell you, it's very easy to identify the sphincter edges once you know what you're looking for. And every labor room I work in now has a dedicated perineal repair kit with these instruments, SIMS, Alice, Mosquito, smaller instruments. And this is something that you can see. And first, you can either do an end-to-end, bring the sphincters together, or you can overlap the sphincters. There are many different techniques. The important thing is identification and repair. Don't be arrogant. Don't think it can't happen to you. And then, like most of my episiotomies, a continuous suture on the mucosa, which I bring to the mucocutaneous junction. And once we've done that, we do the deep and superficial perineal muscles. And then finally, the skin is closed with a subcuticular suture. This is exactly how I do my midline tears when I have this happening in a first or second degree. And this is also exactly how I suture my episiotomies. So I must tell you, if I do an episiotomy, it's always mediolateral. It's never midline. Years ago, I used to do midlines, burnt my fingers once or twice, and decided that while the tear happens in the middle, if it's an episiotomy, let it go to one side. And you can see there, mucocutaneous junction, subcuticular sutures for the skin after doing the deep and superficial perineal muscles. And you can completely have the most cosmetic, most comfortable, and don't be afraid. Train yourself well. If you want to do a training program, I know RCOG does these training programs on perineal repair. And trust me, you will not have a problem. If there's a doubt, if it's difficult, you may want to leave a catheter in the bladder for 24 hours, but that's about it. You can see coming all the way down and then doing a subcuticular to bring the skin together. Finally, let's come to the passenger. Fetal compromise could be both asphyxia or injury, and here we need teamwork. Now, when fetal distress happens, you want to first make sure that you are dealing with the right kind of tracing in the right way. Frequent decelerations on CTG might be physiological. If they are early, they happen in 66% of patients in the last 30 minutes. If my resident says decelerations, I say, go check if she's fully dilated. Head compression with a normal acid-base status is associated with these decelerations. If they are isolated episodes of fetal bradycardia or tachycardia, not alarming. Take a big picture view. But if the late decelerations that happen in maybe 5% of the last 30 minutes and they are persistent, this is an indication for immediate delivery. Now you can see here that this looks quite dramatic, but basically what's happening in the patient with head, there was definitely head compression. This was a 38-week premature rupture of membranes, induction of labor, second stage deceleration. Whenever there is a doubt, I take the patient into DOT, and this particular patient had a phase 2 pubes forceps delivery and all was well. On the other hand, if you've got a fall in fetal heart rate by more than 15, and if you have a fall in fetal heart rate for more than 10 minutes, it's defined as a cerclage. Now, this patient had a cerclage in every pregnancy in 3 pregnancies. She presented in labor was progressing well, and suddenly we had this crazy, extended, persistent deceleration. We rushed to the theater. We published this case because of the fibrosis of the multiple cerclages. She had ruptured her uterus, not up to the cervix, but higher up on one side. And because we picked up this deceleration, which was sinister, we were able to save the baby. What about occipito-posterior positions? Well, firstly, you could have expectant management. Just wait long enough, most of them will turn. You could do a digital rotation, you could do the 5-finger rotation. Usually I find 2 fingers is enough. But as I'm rotating the head, I'm also pushing the shoulders on the abdomen. And then, of course, you could do a vacuum rotation or a forceps delivery. Now, the importance here is, if you're using a partogram, be patient and have fortitude. If you can see here, these are 2 patients where the full dilatation lasted for about 3 hours. They progressed very well and they stayed fully dilated for 3 hours. And by being patient, they both delivered normally. Early decelerations are reassuring. I've told you this before, prolonged second stage in nullies is more than 2 hours and multis is more than 3 hours. And you may wonder what that blue cup of coffee there is doing. Well, it's playing a very, very important part. When an obstetrician is in the labor room with the patient, he starts or she starts getting impatient and angsty. And in this particular case, if you wait long enough, I get out of the labor room, go sit down, have my coffee, sit and do some work. When you come back, most of them will have rotated, most of them will have descended. Now, once in a while, we need something more. And in a challenging birth like this, we needed the forceps. And I'm using the Hayes forceps here. So you could use any forceps. It's a parallel forceps. So I'm first putting in the branch on the right-hand side. You know, in crossed forceps, we always put the left branch first. But I've always said left is easier for me. So why not do the more difficult one first? And with parallel, it's possible. I never tie my patient's legs in a lithotomy position. They are always bracing themselves against the stirrup. So it's a semi-squatting position, though they are on a bed. Lots of vaginal lubrication. And I'll tell you what I've started doing now to stretch the perineum. I use a Sim speculum. I find it to be much gentler than ironing that perineum with your fingers. Just pull and stretch with a Sim speculum with adequate lubrication till the head comes down. Now, the Hayes forceps is unique because I can do it. But again, I'm going to stress, you do not need a Hayes forceps to do this. That's the Saxtorp-Pajot's maneuver. And in this case, you can see the handles going up, 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 up. Now, the only time a handle goes up like this is if you've got a phase 2 pubis baby. And you bring the nape of the neck down all the way to the coccyx and then deliver the baby's head by extension. People say that there are no indications, absolute indications for a forceps. Well, I believe a phase 2 pubis delivery is an absolute indication. And this is a unique new situation we have, the preterm baby. First of all, forceps preferred, vacuum contraindicated. And I've always believed that these babies need that little more help. And today my practice would be incomplete if I wasn't using the Pylese forceps. In fact, every hospital I'm at has a set of the 2 Pylese forceps, the very small ones that I use for the smaller babies, less than 28, 30 weeks when I do a C-section. And this one, which I use till about 30 or 34 weeks. The purpose of using a forceps is to protect and cage the head. This is one time when I will give an episiotomy, even if I think I can get away without it. It's a crossed forceps, so see how I'm not bringing the handles together. I'm letting them stay open and gently, very gently, a millimeter at a time, bring the head down to the introitus and then deliver the head by extension. Again, I just want to tell you, we could have delivered this baby within seconds, but you really take your time to give the baby all the time in the world to adjust to the pressures before the baby is born. And here you can see crowning, episiotomy, that this would have been somewhere around a 33, 34 weeker. And all was well. Now, the one thing that all of us dread, shoulder dystocia. Well, we shouldn't. One is because if you dread something, you can't handle it. This mnemonic has to be on the wall of each and every labor room, everywhere. It's something we practice, but if it's there, it's better. So you call for help, you give an episiotomy, always McRoberts first. Then you could do the suprapubic pressure, which is called the Manzenti's maneuver. You could then do the enter maneuvers, remove the posterior arm. I often do that, or the Gaskins maneuver. Now here we were lucky that while we were delivering a baby, not too big, we did land up with a bit of a shoulder dystocia. And you can see here that you can gradually go. You delivered the head. Maybe I should have waited for a little while longer. And the moment I delivered the head, the baby stopped budging. Like the turtle sign, the head went and jammed itself against the perineum. I got the pediatrician to clear the airways. There is no panic at the moment. And then you do the McRoberts maneuver where she was asked to completely flex her legs, her thighs. And you can now see someone giving suprapubic pressure. There, hyperflexion, McRoberts. And when you do that, the baby slips out like magic. And of course, you should also know about the corkscrew maneuver. That's the Woods maneuver and the Gaskins rollover maneuver. Finally, I'm adding an extra P, and that's the procedure when it comes to operative obstetrics. Because Andrew Carnegie has said what one does easily, one does well. The American College, the college of the country with the maximum litigation, says many cesareans may be avoided if operative delivery is an option. It says that operative vaginal delivery can achieve or expedite safe delivery for a number of indications. And the risk is so low that level A evidence says that it's acceptable, right? The only thing is be prepared for anything. So I'm very liberal in these cases to take my patient into the OT, keep everything ready for both and do what's best for her afterwards. In complicated instrumentation, you have complications, so you avoid it. That means you have to stay with the prerequisites. I am not going to read the prerequisites to an audience of experienced gynecologists, but I'm just going to read the last one. An operator who knows when to stop, not to force the issue, and not to aggressively use forceps and vacuum in combination. A difficult forceps followed by a difficult vacuum or vice versa has major complications. It's not to say once in a while you turn it and then do an outlet forceps, but by and large, you have to be careful. Second stage C-sections are challenging, which is why wherever possible, I'd like to deliver the baby vaginally. You do a trial instrumentation, the OT, be prepared for everything, including an emergency cesarean section. It's usually a very deeply engaged head. There might be signs of impending rupture. The patient is given a Trendelenburg position and uterine relaxant anesthesia. But the important thing is make the incision right. Don't make the same incision for all. If you're planning to displace the head vaginally or manually or use a vectis or a forceps, take the incision low down over the biparietal diameter. If you're planning to do a Patwardhan's maneuver, take a high incision at the level of the shoulders. Push technique, we know, put your fingers in like a cone and have an assistant push up the head. Forceps is something that I think everyone should master when they're doing a cesarean. Well, for me, I must confess it's a routine. But the reason why I say this is in certain situations, complicated situations, it gives you control like nothing else can. Particularly when you've got a difficult, deeply engaged head or a floating head. And by doing a forceps, not only can you make a more reasonable incision, but you have better traction and not depending upon the anesthetist constantly trying to push the baby out, which you can all know that it often is so difficult and the baby goes all over the place, particularly with an anterior placenta previa. Lateral application, flex the head, deliver by extension, and trust me, in difficult situations, this is absolutely a lifesaver. What about the Patwardhan's method? Patwardhan's method is called the pull technique. You first deliver the arms and the shoulders, then the trunk, then the legs, and finally the head. Okay, and it's something that we must all be kind of familiar with. So I'm going to end here And maybe if you've got time, we could do certain questions and answers by quoting 3 people I admire greatly. Winston Churchill. He advised the obstetrician, do not freeze. When going through hell, keep going. No matter how difficult the situation, don't panic. You will always find your way out. The second is Napoleon Hill. He said, patience, persistence, and perspiration make an unbeatable combination for success. And finally, the oldest evidence-based person of them all, Hippocrates, who said, primum non nocere, first do no harm. So thank you very much, Meenu, Vaishali, the presidents of the 2 societies. It's been a privilege being here this afternoon. And let's all do good for the women we look after and give them the best and the safest possible experience that they deserve. Thank you.
Thank you very, very much. Dr. Noza, your presentation was, it was so nice, so gently you took us through the second stage of labor. I'm sure your patients must be so happy in your hands. You're so gentle, you're so soft, you're so skilled, and yet you know where to draw a line. So I think, and when to take the patient for a C-section. So Dr. Prasanna Kumari and the chairpersons can put in their comments. Thank you very much.
Sir, listening to you, I'm lost for words. What a talk and what beautiful videos, and just, far away, like it's like we are with you in the labor room and we are watching you operate like we were 30 years ago at Wadia. We used to watch you operate and watch you deliver and listen to your lectures. And I think as an undergraduate student, I've heard your lectures, and that inspired many of us to take up gynecology. So, sir, it was absolutely very mesmerizing, emotional to watch you operate and the way you guided us. Yeah, I have a few questions, sir, actually. I want to know the no episiotomy even in a primigravida. So, does this delay the time of delivery? Does it extend labor? So, you're on the mute, I think. So you're on the mute.
Yeah. So firstly, let's not make it about time. One thing we have to decide when we do obstetrics is to be very patient. No, it really doesn't. Because an episiotomy is not helping the baby come down from a higher station. By the time an episiotomy is given, the baby is already on the perineum. I told you, and I confess that I use a lot of vacuum. So for me, that doesn't delay that part of labor at all. The only thing that I learned how to do, and I'll tell you how it happened, Vaishali. Here I was teaching my students right from my Wadia days that an episiotomy is a surgical incision, a perineal tear is a roadside injury, and a surgical incision is better. But evidence said otherwise. Cochrane said otherwise. Guidelines of every society in the world said otherwise. How can I be a less effective obstetrician than all those people? I did it hesitantly first because I really didn't have any roadmap. I surprised myself with how women deliver normally, and some of those women have had babies of even 4 kilos and still delivered without an episiotomy. Now, please get what I'm saying. I'm not saying what the West often does, where they do a no episiotomy and let whatever tear happen. I say selected episiotomies, selective episiotomies. And today I find it surprises me, and very often the people in my labor room, 85% don't need it. Same patients as all of you, same so-called Indian rigid perineum, same smaller mothers, same sometimes larger babies, and it's possible. Today, patients are going to start challenging us because patients go online, and one of the first things they'll probably come across in a birth plan is no episiotomy. Why wait for them to push us? Why not do it ourselves? And I'm not exaggerating. The extensions are more with an episiotomy. Sometimes sphincter damage is more with an episiotomy. It doesn't happen with a perineal tear.
Right. Dr. Nosir, you were excellent in your going through the first stage, second stage, and third stage. I have a few comments now. In the first stage, This is all for the coming up obstetricians, for the juniors. In the first stage, the patient should be possibly given a companion, and she should be allowed to walk around. She should be allowed to pass urine. She should be allowed to take fluids, and you can give fluids up to some 2 hours before cesarean. So she can be given fluids, and if you are not giving oral fluids, of course you have to give IV fluids, and give enough time. Up to 6 centimeter dilatation, we need not interfere. So I join you in your comments on this, giving time. That is what exactly misbehaved by obstetricians. Don't panic, don't hurry. But when you have to interfere, you have to interfere. So the continuous CTG monitoring on pitocin, on oxytocin or previous card uterus, it has to be there. And resist the temptation to start oxytocin before she is 6 centimeters. When she is 6 centimeters, you can give sufficient time for her to become 6 centimeters. One patient may reach by 1 or 2 hours. Another patient may reach by 6 to 8 hours or even more. So give her time if mother and baby are okay. And in the second stage, resist. I join you in telling that resist the temptation to deliver when the head is full. It has to come to the perineum. You can give sufficient time to come to the perineum. And don't deliver, as you said, when there is no contraction. You will be encountering torrential atonic postpartum hemorrhage. And liberal use of vacuum. If it is properly used, it will only help the baby and the mother. And when you deliver, it should be like a music. It should be slow, and you should be calm and collected. And don't hurry, don't panic. And follow the natural birth canal and deliver the baby as you have shown. Gradually, it will come. The delivery will be like a music for you, the baby and the patient. So it should be like that. And after all the delivery, you have to see the episiotomy, whether the sphincters are all right or not. The sphincter will be beefy red. It has to be repaired. I really appreciate you keeping the instruments ready for suturing the perineal tears. And for the fresh tear, I think end-to-end anastomosis will suffice. For the old repair, actually, it should be overlapping method. Otherwise, it can fail. So rectal examination should be done for all patients with tear or with episiotomy. And when it comes to shoulder dystocia, when it is real turtlenecking, it can be bilateral shoulder dystocia, where all your maneuvers will fail. So this can be made out when you find it is turtlenecking, you do a vaginal examination. And when you find that only the neck is in the pelvis, don't pull, don't go McRoberts. All your methods will fail. And do a vaginal examination, see that at least one of the shoulder is in the pelvis, then you go about all these. Posterior arm delivery is the best method, as you said. Put your hand boldly into the sacral hollow, identify the cubital fossa, bring down the arm. And if still you have difficulty, you rotate and deliver. So if it is bilateral shoulder dystocia, reposition the head. I've done it. Bilateral shoulder dystocia, otherwise you will end up in trouble. Reposition the head. It will easily go in. You will think that it may not go in. I'm talking to the junior gynecologists in this webinar. So you reverse. You need not have to reverse. It will not restitute. It will remain anteroposteriorly like that. So you just push the sinciput up. It will easily go in if it is bilateral shoulder dystocia. They can easily deliver by cesarean. All the shoulders will be above, so there will not be any problem. And for the impacted shoulder head, I think Patwardhan's method is the best. Patwardhan is the best. And when you do the Patwardhan, the impacted shoulder, the lower segment will be greatly dilated. So you are likely to go for a lower incision, tearing the parametrium and the ureter in switches. You can include it in switches. So measure the lower segment, maybe 5 centimeter, maybe 10 centimeter. Sorry. Yeah, and put your incision in the middle of the lower segment. Then you will not be higher up, you will not be lower down. Put your hand, deliver the shoulders, then the chest, and then the limbs, and then the head. It will easily come. That is the best method, I think. Dr. Patwardhan should be appreciated. So I think really I enjoyed your talk, and I join you in all this waiting, and be calm and collected. Go have a cup of coffee and come, but you should not miss an abnormal CTG or any abnormality in labor. So give sufficient time if everything is fine, and you have to interfere when it is needed. So thank you so much, Dr. Nasser. It is really exemplary.
Thank you.
I remember all your codes.
Thank you, ma'am, for summarizing so beautifully. And sir, truly, these are invaluable words of wisdom spoken by a legend, and truly an honor and privilege to hear you today, sir. Charu?
Yeah, I mean, words are falling short. I just made sure that nobody entered the consulting room because it was such an enthralling lecture. And I think it is my misfortune that I have never really heard sir so much. But I am blessed, thanks to Dr. Meenu, that, to be a part of this webinar. And so I got to listen to such words of wisdom from Dr. Noser. Sir, we are really blessed and honored to have you today as such an esteemed speaker for such a wonderful topic, which you handled with such grace and elan. I mean, it was really mind-blowing. Thank you so much, sir. Thank you. It has given us more inspiration to, to do more normals, wait longer, and yeah, the cup of coffee can become 2 or 3 also. Thank you. Thank you.
Thank you, sir. So now we move on to the next session. For the next session, I would like to call upon our chairpersons, our esteemed chairpersons, Dr. Beena Kumari Madam. She is the professor and head of the Department of OBGYN, Government Medical College, Kottayam. She is the president of Kottayam OBGYN Society. She is the state coordinator of Medical Education Committee, FOXI 22-23. She is the organizing convener of AKCOG 2020, Eugene PG Examiner and Thesis Guide. She's published papers in various journals, and her areas of interest include high-risk pregnancy and vaginal surgery. Our next welcome, ma'am. Our next chairperson is Brigadier Sanjay Singh, sir. He's the head of the Department of OBGYN at the AFMC at the Armed Forces Medical College. He was an ex-professor in HOD ACMS Delhi. He's a UG, PG, and DNB examiner and paper setter. He's published 54 research papers, 4 AFMRC projects, and 6 chapters in books. Has received the Best Researcher Award from ACMS Delhi. He's received Most Meritorious Research Award for an AFMRC project. He's the first gynac to become AHA accredited basic life support and advanced cardiac life support course instructor. Welcome, sir. I would request Beena Kumari Madam to please introduce Dr. Meenu Agarwal, ma'am, our next speaker. She'll be speaking on follicular monitoring in IUI.
Thank you, Pune ONG Society. Can you hear me?
Yes, we can hear
Hello.
you.
Okay.
Yes, ma'am, we can hear.
Yeah. Just first 2 days are okay, madam. No problem.
Okay. Welcome, Dr. Meenu, the lovely lady, President of Pune Obstetric and Gynecological Society. She is elected Secretary General, International Society of Gynecological Endoscopy, FOXI Imaging Science Committee Chairperson, and she's a Bachelor in Reproductive Endoscopic Surgery and a course director of endoscopy and ART training courses in UAE. She has got many awards: India Great Leaders Award, Icons of Health Award, and FOXI Champion of FOXI Award. Let's hear from you, Dr. Meenu, regarding the follicular monitoring in IUI. Welcome.
Thank you very much, respected chairpersons, Dr. Beena Kumari Madam and Dr. Sanjay Singh sir. So it's my privilege and honor to be presenting here in front of all of you who are such great senior people over here. And I hope that I can give some take-home messages to the junior colleagues who have joined for this particular webinar. So I'm very happy that we had very good guests of honor and our chief guest and the chairpersons for both the sessions. and also very happy to associate with two societies, Adura Society and Kottayam Society. So I shall be talking on ultrasound and in infertility and follicular monitoring. It seems like a very, very basic topic, but I remember, when we were in medical college, we didn't have access to the ultrasound machine. However, the students now are more fortunate than us, and they are actually, they can do the ultrasounds, both gynec and obstetrics. So for us, it was a tough journey, but I still would urge the practicing gynecologist and obstetrician that a basic ultrasound, both infertility and obstetric, should be, they should be able to understand and do a basic. That was my advocacy when I was the chairperson of Imaging Science Committee, FOXY. Patient is much more comfortable in your own, at the gynecologist clinic. We are also much more comfortable because when we are doing the ultrasound, we are used to doing PV examinations. So for us, TVS is very simple. But for radiologists, TVS is a headache. They will always do an abdominal ultrasound, even if you tell the patient or you write on a note for a transvaginal sonography. Of course, time management is much better. You can do damage control at your center when you're doing the ultrasound as compared to when you get the reports from outside. So what all do we see in an infertility patient who's coming in for an ultrasound? So first of all, we look for whether how much is the endometrial thickness. At any time she's come day 14, day 15, day 21. Suppose we find very thick endometrial lining. What we do at our center, we keep an IUI catheter and normal saline always in the OPD, and we push little normal saline into the transcervically, and you can see over here some fluid and the floating polyp. So you know what we have to do next for this particular patient. So this immediately gives you a diagnosis. You can also put a color Doppler at the same time, and if it is a single vessel supplying, it confirms your diagnosis and also tells you that when you remove this polyp, suppose you're using scissors, we must coagulate the base with the bipolar. Whenever we find one wall thicker than the other wall, it is adenomyosis unless proved otherwise. Go to the endomyometrial junction, make a small window and then zoom it. So if you find some obliteration of this area endomyometrial junction, then you know that this patient has lesser prognosis, is not that good. So maybe if she is not doing well for IUI, she could probably go for an IVF with prolonged down regulation and then embryo transfer. Tubes have to be visualized. Just open fallopian tubes on HSG is not good enough if she is not conceiving. So whenever we are doing an ultrasound, iliac vessels are always kept as a landmark. Medial to the iliac vessels, you will find the ovaries. Normal fallopian tubes are not appreciated on ultrasound, and if we find any tubular structure lying in there, it has to be a dilated fallopian tube, which could be hydrosalpinx, pyosalpinx, or sometimes ectopics. My very, very junior colleagues, and Sandhya is there right now with me here on this platform. So they pick up ectopic pregnancy very quickly because that is what they're doing all the time, transvaginal sonographies. So it becomes very easy for them to pick up. Fibroid uterus, again, very, very important is to map the fibroid, know exactly where the fibroid is lying, and accordingly, then whether to remove the fibroid or not to remove the fibroid. So many publications, different types of fibroids. Definitely submucous fibroids should be always removed in cases of infertility. Intramural is plus minus depending on the, again, the indication. Suppose male factor infertility, intramural, probably you will not remove it immediately, and subserous need not be touched. Isthmocele is another now an entity which is very commonly seen. For the junior colleagues, whenever you are doing an ultrasound with a history of previous C-section, even if she has no complaints of any postmenstrual bleeding, spotting, or infertility maybe, look for the presence of isthmocele. So your eyes will get tuned to looking at isthmocele. And then when actually the patient comes with the symptoms of isthmocele, then you can quickly diagnose it and then treat it according whether whether she wants fertility, whether the AUB is the main concern. So you can either go for hysteroscopic or a laparoscopic management. So whenever the patient is coming for fertility management, generally we like to call the patient on day 2 for first ultrasound. All right, on day 2 we find some follicles sitting there. Now, ये follicles कहाँ से आए? These follicles have come from the luteal phase of the previous cycle. So there is a wave of stimulation in the luteal phase, also in the follicular phase. So from those follicles have responded, and these follicles, but they did not respond very well. So they did not ovulate in the luteal phase. However, now they are optimal in the follicular phase of the coming cycle, and that is when you will find these antral follicle. Now, again, it is very important to understand this particular diagram here. You see, these are the primordial follicles, primary, secondary, pre-antral follicles. Then these are the antral follicles. It takes almost 2 months. Now, these, what are the, जब हम लोग ultrasound करते हैं, second day पे, we see 4 antral follicles on one side, 5 on the other side. What does it tell you? So these are the follicles which have been recruited like soldiers at the border by the system of the body. Now, out of these follicles, slowly and slowly, one follicle will start growing. So this is called a selection of the follicle. So out of 4, after 2 days or 3 days, you may find one follicle larger than the other. So this is the selected follicle. However, there may be another follicle lying next to it, which also is large, but not as large as this. So then comes the dominance. The dominance, maybe the selected follicle will become dominant, or maybe another follicle lying next to it becomes the dominant. Now, this dominant follicle, which is seen on around day 10, day 11, from day 7 onwards, will then slowly become the ovulatory follicle. The other follicles will slowly and slowly die out. Why is this graph important to us? 2 reasons. One is, suppose the patient of an IVF cycle, she asks you, ki, okay, you are removing every time 5, 5, 10, 10 eggs from my ovaries. Are you reducing my egg count? So we can show her this diagram and tell her that these follicles would have undergone atresia, but because we stimulated, so we could also harvest these follicles. Second very, very important thing from this diagram, we understand when to add HMG. Very important for us to understand. Why? Because if we add HMG here at this stage, what will happen? All follicles will start growing. So we must add HMG only when we see a dominant follicle. So once we see a dominant follicle on day 6, day 7, day 8, that is the time to add HMG. Third very important thing is, again, this dominant follicle starts producing its own FSH. Okay, so it does not now, because the estrogen is rising, it is causing a negative feedback. Because of the negative feedback, the smaller follicles are disintegrated and this bigger follicle is growing. Now, if we want to add estrogen in a patient who has a thin endometrium, again, add estrogen when you see a dominant follicle. So these are the 3 things that we must remember: adding of gonadotrophins when you see the dominant follicle, adding of estrogen when you see the dominant follicle. And of course, if we add HMG too soon, then all these follicles will come up, and then you will be in a dilemma whether to do an IUI or to cancel the cycle or to convert the patient to IVF. So not to add gonadotrophins too early, because then we are stimulating all the follicles. And as the time advances, the follicle grows 1 to 2 millimeters per day and up to maximum of about 18 to 20 at the time of ovulation. And as the dominant follicle grows, the smaller follicle size and the number reduces. Again, a very important part is that LS surge. Now, suppose you do an ultrasound and you find that it has got a very good blood supply all around. Okay. It looks pre-ovulatory to you. What must you do? We must do a urine test. If the urine LH is positive, or you can also do a blood test for LH, serum LH. That means she has already got an LH surge. Whether you give HCG, don't give HCG, does not matter. She already has an LH surge and she will ovulate in the next 24 hours. So this is the patient where you can also do an early IUI for her and not wait for the HCG injection and then 36 hours. Okay, so that is the importance of the LH surge. And also, sometimes all of us get patients where they come and say, Doctor, mera follicle rupture hi nahi hota, maza follicle rupture hot nahi. Why? Because when we have given HCG today, we call the patient after 36 hours for IUI, and before IUI, we do an ultrasound, and we find that the follicle is sitting right there very nicely, no rupture. Because rupture can take more than 36 hours, number one. Number two, rupture is not an event कि suddenly balloon है and suddenly वो collapse हो गया. It is a slow process. So very slowly the follicle will start shrinking in size. Then you will see some echogenic areas in the follicle, and you will see some free fluid around the follicle and in the pouch of Douglas. So that will be the sign of ovulation, which can come in 36 hours or sometimes in 42 to 46 hours as well. This is how the corpus luteum will look like, and a secretory endometrium will look like, which will tell you that this particular patient has ovulated well. Now again, endometrial evaluation is very, very important. Both thickness of the endometrium, also the trilaminar pattern. So pattern and thickness, both are very, very important that we have to keep in mind. So this is how the grading should be done. This is grade A. You can see a nice triple line endometrium. This is grade B, where this intervening area is not as echogenic as the myometrium, and this is grade C. Grade C we should cancel because this patient, either you will not get a pregnancy, or even if you get a pregnancy, very high chances of having losing the pregnancy in the first trimester. Then you can put the color Doppler and again look at how much is the blood flow to the endometrium. You see here, this is fantastic, wonderful. Zone 3 and zone 4 are very, very good. Again, zone 2 and zone 1, very less chances of getting a pregnancy. Even if we get a pregnancy, again, very high chance that the pregnancy, we may lose it in the first trimester. Then how do we troubleshoot? See, sometimes ultrasound kar rahe hain, day 7, day 8 पे we see a large follicle. Now this follicle, whether I should give HCG, whether I should cancel the cycle, what do I do? So this is the question mark. So these follicles, they are actually follicles which are coming from the previous cycle. So वो previous luteal phase में कुछ dominant follicle है which is grown now with whatever you have given, letrozole or clomiphene, and now this is appearing on day 6 or day 7 of the cycle. This is generally an empty follicle. So what you can do is, you can do an E2 values. If E2 is less than maybe 100 picogram per ml, then you can ignore this follicle and follow if you have another follicle lying next to it, which may be 13-14 millimeters in size. Give HMG as per the other follicle, follow that follicle. If you get the pregnancy in this cycle, you will still find this particular follicle as a cyst lying in one of the ovaries, harmless nuisance value, and it may also may be seen if the patient does not conceive on day 2 of the ultrasound. Another important thing is luteinized unruptured follicle, which is mostly seen in patients who have PID or who have endometriosis. in Pune, we have a lot of this IT couple. They do their own testing at home, LH test. Everything is available on Google these days. Nothing wrong in it. I mean, it's absolutely fine. Why should they travel all the way to the clinic when they know what to do, at least to the basic level? And they have physical contact depending on their LH surge. No pregnancy, they come to us. We do all the tests. And what we actually find also in unexplained infertility, that there is no rupture happening. However, there is a luteinization. So the LS surge has come, but the follicle does not release the oocyte. So there is no free fluid in the pouch of Douglas. There is no shrinking of the follicle, but there is a secretory changes seen on the endometrium. LH is positive. If you do serum progesterone, that will also be high. So how to manage? These are the patients where sometimes mild to moderate endometriosis not seen on ultrasound. You do a laparoscopy and you do an adhesiolysis, and these patients conceive very fast later. Another thing what you can do in such cases is, now clearly the LH is not acting well on this follicle. So in the subsequent cycle, once you have the follicle reach 14, 15 or 16 mm, that is the time to give her antagonist. Single injection of antagonist 0.25 along with HMG either 75 or 150 depending on what is the BMI of the patient. Now this antagonist will suppress the LH. Okay, but by default it will also suppress the FSH, so that is why we have given an HMG. So 1 or 2 days of antagonist along with HMG, and then you give the trigger with SCG. Excellent results in cases of unexplained infertility or in cases of luteinized unruptured follicle where everything else is fine and the patient is not conceiving with IUI. PCO patients, again, a bit of a challenge when you are monitoring these follicles. Sometimes you have given Letrozole, you have given metformin, there is no growth. Now, what to do? So, these patients, you can take them on chronic low-dose gonadotrophins. So, we start with, now, the first diagram, if you remember, we saw where we saw that graph, right? That is, one moment, here. So here we are getting the gonadotrophin here. So what we want to do is we want to give very low dose so that only one follicle grows. We don't want all the follicle to grow. So we give gonadotrophins again high, very low dose 37.5. You give it for about 4 to 5 days, and after 4 to 5 days you repeat an ultrasound, and then you see if you have a single dominant follicle. If you have a single dominant follicle, then you continue with the same dose. And once this follicle reaches 17, 18 or 19 mm, that is the time you give trigger with SCG. If you don't get a leading follicle with 37.5, then we can increase the dose to 75. Okay, and then again wait for 5 days. And once you see a single dominant follicle, then continue with the same dose. One more question a lot of people ask me, ma'am, what should be the trigger? Should it be SCG or should it be agonist? Now, agonist trigger will cause a initial flare-up effect and will cause a rise in LH. However, it is a short-lasting. SCG is long-lasting. So when you have a single follicle, you are not worried about any OHSS. So then always, in my opinion, use SCG. There are many publications to support SCG in favor of SCG as against agonist. So for an IUI cycle, SCG trigger is good enough. No need to give agonist trigger, but you do have a corpus luteum which will take over after some time. So those 4 or 5 days of SCG will be good for the pregnancy. Excuse me, if the patient conceives. Again, how to measure the follicle? It should always be in 2 dimensions, and then you take the average of the 2. This is how the measurement should be done. And you can put a color Doppler, and if it has a good color flow, at least 3/4 of the follicle is surrounded by the color flow, that means it has got a, probably it is an ovulatory follicle. Whenever you are in doubt, just do the E2 values. That will tell you whether it is an empty follicle or it contains an oocyte. Sorry. So ovulatory dominant follicle is what we want for all our patients of IUI. Atretic dominant follicle, which may come up, but this is only nuisance value. We should be able to recognize and then ignore it. Okay, it wants an attention, but we can ignore it and then go for the another follicle which is lying next to it. And anovulatory, that means unruptured luteinized follicle. Again, we should have very sharp sense to diagnose these patients. And then in these particular cases, either of course, if patient has endometriosis, you can by all means go for laparoscopy, or these patients may do very well with the combination of antagonist and HMG. So again, as I said, why should it be monitored by the gynecologist? So we should monitor both follicular and endometrium. When to add antagonist, we should understand when to do the E2 values, how to do the troubleshooting, when we are scanning the patient, and of course, timing of the IUI is very, very important. So thank you very much. Thank you for your kind attention. And if there are any questions, we can take them. Thank you.
Thank you, madam. That was a very informative session. Sanjay sir, your comments,
Yeah,
please.
I thought that there'll be some question from ma'am, because ma'am is a very good teacher. So if there is no question, then I'll conclude this session. Is there any question, ma'am? Is there any written question
Let me
that has
check
come
the
onto
chat box, sir. Actually, no questions have come.
Acha, there is no question. Then I'll conclude this session. Thank you so much, ma'am, for a very nice and lucid presentation, like an excellent and good teacher that the students like to listen to.
Sir, from
fact, let me,
AFMC, sir, from AFMC, sir.
ma'am, let me tell you that this was the best presentation that I got an opportunity to hear for the first time. In fact, I'll say on this topic. And I'm sure the target audience would have been immensely benefited with your endeavor. It is amply clear from your presentation that initially when you do the baseline USG, it is of paramount importance to evaluate the uterine as well as adnexal pathology that you started with. And then subsequently, it is also useful to assess the ovarian reserve for the evaluation of the optimal dose of IUI or whatever protocol do you follow to adjust the dose of the drugs, as some patients are hyper responsive and some patients are poor responders. Most importantly, to time the IUI and to avoid excessive stimulation and prevent OHS. That is again very important thing that you brought it out, ma'am. You also brought out that the baseline scan, the pre and post ovulatory scan are important from their own rights. And apart from this, lastly, you also talked about the thickness and the quality of the endometrial lining, which is also important for the successful outcome of the pregnancy. If I have to convey one message to the august audience who are listening to you, will be the first line and the last line that you said, that every gynecologist should be able to do a good ultrasound in
Ultrasonography, yes.
At least this is what we are following there at AFMC. So thank you so much, ma'am, once again for your insightful talk.
Thank you, sir. Thank you very much for
Just one question, Dr. Meenu. Do you do one or two IUIs in your clinic? Like, what is your results with both?
Yes, see, most of the publications have shown that there is no advantage of doing two IUIs. So then if you go by the evidence-based data, then there is no advantage to go on only for single IUI. There is a very nice paper which has recently come up where they first did the IUI and then gave the SCG. Not in male factor, and explaining in other cases, and they found the pregnancy rates were better. But it was a very small study, so maybe more studies will come up on this. So I feel that the sperm is there for 24 to 36 hours. It lasts longer as compared to the egg. So they first did the IUI and then gave the SCG. So very,
Okay.
yeah. So that is a very nice paper which has come up very recently this month only. Thank you.
Have you ever come across OHSs in the stimulation protocols, like in for IUI?
Yes, madam. I do get patients from my colleagues and friends, and they say ki we did a stimulation and now I can see 4 or 5 on each side. What do I do? So they send the patient to me. So there are 2-3 ways to tackle these cases. One is, of course, cancel the cycle. So when we say cancel the cycle, it does not mean that we don't do anything, because she will still get an endogenous LS surge and all follicles may still rupture. The husband may not still listen to her and they may still have contact, and she may come up with a multiple pregnancy and OHSS.
Correct.
So whenever we are cancelling the cycle, it is important to give antagonist, because we want the LH to break down. So
Okay, correct.
antagonist for 2 or 3 days, then put her on progesterone for the next 1 week and get a withdrawal bleeding. So that is
Oh,
cancellation. Second thing is, we can take the patient under anesthesia, puncture 3 follicles on each side, 6 hours after giving the HCG trigger, remove 6 eggs, keep 2 follicles there, and then do IUI. And
Oh,
third,
correct.
of course, if we can convert it into a IVF cycle.
IVF cycle, correct, correct. Okay. Very enlightening talk it was, of course. You touched even from the basics of ultrasonography, which is very, very much needed, especially the ultrasonography, like demonstration of the polyps and all, which can be easily missed, like and also the fibroids. So many people are doing unnecessary myomectomies, which can even have a contributory factor because of the adhesions, which is developing later on, and then like that. Okay, it was very nice.
Thank you, madam.
Thank you so much for giving this chance to be with you, Pune people. Actually, I have a colleague, Dr. Swapnali, near Pune, that she's practicing in the medical college. Yeah.
Thank you so much, madam. And we are looking forward to seeing all of you in AMOGS this week.
Thank you very much.
Fantastic talk by Dr. Meenu. It is always a pleasure to listen to Dr. Meenu Agarwal. And she has been rightly described, as one of the stalwarts as far as imaging and infertility as well as laparoscopy is concerned. We are really very, very blessed to be working with a president like Dr. Meenu. And Dr. Vaishali and myself have gained so many insights and have learned so many new ways of leadership, which Dr. Meenu has. She's a truly capable leader, and we wish to see her fulfill all her dreams and lead in a better and bigger way. Thank you, Dr. Meenu Agarwal. Like any other program, this too program deserves a small vote of thanks. I take the opportunity to thank everybody who has contributed to this wonderful webinar. At the outset, I want to thank Dr. Hema Devakar, Madam, Chief Guest of today's webinar, for having spared her valuable time in spite of her busy schedule. It is always a pleasure to meet Dr. Ramani Devi and Dr. Aswath, who are stalwarts in FOXY and have done a lot to contribute to knowledge far and wide to all the obstetricians and gynecologists. Our esteemed chairpersons from Adur Society and the other Kerala societies have really taken all the efforts to make sure that this webinar has been a success. And so, Dr. Beena Kumari, thank you for being here. Dr. Prasanna Madam, thank you for sparing your valuable time. Dr. Vaishali Chavan and Dr. Sanjay Singh, your contribution to this webinar have been immense. And last but not the least, I think what Dr. Noser Shariar taught us today has been mind-blowing and outstanding. And I think if all of us can practice obstetrics with that much of guts and courage, then, we will surely be able to bring down the rising rate of C-section and reach the targets that have been laid out to us by the national and international organizations. Dr. Meenu, always a pleasure to work with you, for you, and we look forward to many more such webinars. And of course, our young Dr. Sandhya Meshram, who has been conducting the cutting edge webinars with so much grace and elan. Thank you so much, Sandhya, for always being there. As you know, inspired and guided by Dr. Vaishali and Meenu, calling everybody, making all the arrangements for the webinar is not a small task, and you're learning all this at such a young age. So that is really, really good for you. And of course, BSV stands behind all of us like a strong support. Their platform, Mr. Prasad Kulkarni, Mr. Zamdar have always been there to look into the nitty-gritties and make sure that the flyers and the brochures are ready on time. I think Mr. Rajiv Agarwal is the driving force behind the BSV currently. And so we are so happy to have a familiar face who always supports all our academic endeavors. Thank you so much for being a part of this webinar. Our delegates, we cannot forget our delegates. I heard that today we had a very record number of delegates for this particular webinar. And I think any speaker is most happy when there is a great audience in front of them. So thank you, dear delegates, for being a part of this webinar. Thank you very much. Thank you, Vaishali. Thank you, Meenu. Always a pleasure to be a part of these webinars.
Thank you. Thank you for
Thank you,
teaching us
madam.
to
Thank you
be
so much,
to
ma'am.
relax and be patient. Thank you.
Thank
Thank you,
Thank you so
madam.
much.
Go offline.